Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevu. This is Season 1, Episode 6, Surgery. This is a series on my YouTube channel where we'll look at 6 clinical questions in 1 clinical course. If you haven't yet subscribed to the channel, you already know the drill. We're about to hit 500, so we shall do a countdown on the channel with every single video that is going to be released. And currently, at the time of recording of this video, we were at 482 subscribers. So please share the link to Zambia and beyond. And apologies for not coming through yesterday on the double videos in a day. We had a social media blackout, as you already noticed. And speaking of social media blackouts, you can now find us on Facebook, search Dr. MK7, and please like the page because most of the updates are going to be made there. So grab your piece of paper, grab your pen, and let's go. So beginning with our question 1, write short notes on Steele's rule and on hydrocephalus. So remember that the stability of the atlantoaxial articulation or the atlantoaxial joint depends fundamentally on the integrity of 1, the odontoid process, and 2, the ligaments. That's your opening statement. And the anteroposterior diameter of the ring of the atlas is going to be approximately 3 centimeters. Okay, so if you measure the diameter of the anteroposterior diameter of the ring of the atlas, it's roughly 3 centimeters. That's your second point. And you're going to have the spinal cord and the odontoid process having occupied approximately 1 centimeter of those 3 centimeters. So it means that the odontoid process will have a centimeter. The spinal cord will have a centimeter, so approximately 1/3 is going to be occupied by the spinal cord, another third is going to be occupied by the odontoid process, and another third is going to be a space, just an empty space, which is usually filled with CSF. So when you're talking about Steele's rule is, you can refer to it as Steele's rule of thirds, states that an area inside the atlas is equally occupied by thirds by the following things: the atlas, or rather the dens or the odontoid process, the spinal cord itself, and a space. And then this space is primarily going to be occupied by cerebrospinal fluid. So this is going to be allowing for some degree of pathological displacement, especially when you have fractures of the odontoid process. It can be displaced, but then because of this 1 centimeter space that you have in this region, it means that you can still allow for some displacement to occur before you actually even get any neurological impairment. So in the presence of any atlantoaxial instability, there is a safe zone that may decrease the risk of spinal injury. And that's about Steele's rule. Then write short notes on hydrocephalus. So remember that hydrocephalus is increased in CSF, cerebrospinal fluid, under pressure within the ventricles of the brain. It is as a result of either number 1, blockage of CSF flow, or number 2, decreased production of CSF, or rarely it may be caused by an increase in CSF. So there are types of hydrocephalus. There is what is known as a non-communicating, or you can refer to it as obstructive. So here there's going to be an obstruction that's going to be there to the flow of CSF in the ventricular system. You could have some congenital causes such as congenital aqueduct stenosis. You could have Dandy-Walker malformations. And in Dandy-Walker malformations, that's where you have the absence of the cerebellar vermis. Remember that you have the 4th ventricle being found at the level of the cerebellum. Then, in addition to having this absence of the cerebellar vermis, you also have this cystic dilatation or cystic enlargement of the 4th ventricle, most likely a posterior fossa cyst. Then another condition could be Arnold-Chiari type 2 malformation, where you have downwards displacement of the cerebellum and the medulla through this foramen magnum into the cervical spine. You may also have tumors, predominantly gliomas, but these are obviously acquired causes. With the most common tumors, CNS, are going to be the gliomas, things like astrocytomas, ependymomas. Then you have communicating type of hydrocephalus, where there is no blockage, but there is either increased production of CSF, like for example, if you have a tumor that's a papilloma of the choroid plexus that's producing CSF, or decreased absorption, like for example, in infectious conditions like bacterial meningitis. Sometimes you may have normal pressure hydrocephalus, where there is hydrocephalus, but the pressure within the ventricles is actually normal. Then you may also have a false type of hydrocephalus. It's not really a true type of hydrocephalus. That's known as hydrocephalus ex vacuo. So this is often seen where you have compensatory dilatation of the ventricles, often due to atrophy of the brain. Then clinical features of hydrocephalus are going to include things like a large anterior and posterior fontanelle. There may be splitting of the sutures. There may be sunset eyes. There may be prominent scalp vessels that are dilated. You may get a crackpot sound on percussion of the head. I don't know what happened to my English right there. And you may have features of increased intracranial pressure. So bulging of the fontanelle, projectile vomiting, headaches, seizures. Then management of the condition could be medical, where we want to address the underlying cause. If it's meningitis, we treat the meningitis. Then acetazolamide can actually be given as it decreases the production of CSF in mildly, slowly, progressively accumulating hydrocephalus. Then you may also perform surgical interventions where you put a shunt. There are different types of shunts, such as a ventricular peritoneal, ventricular lumbar, ventricular atrial, ventricular pleural, ventricular spinal, as well as ventricular osseous. Moving on to the next question. So a patient is brought to the emergency department after being bitten by an elapid, a cobra snake. Discuss the initial assessment and management. So this is obviously an emergency. So the first time that the patient comes to your hospital or to the emergency department, you're going to want to do your primary survey. Remember, with all patients that are critical patients, you want to do your primary survey first. Then you can move on to do your secondary survey and eventually your tertiary survey. So you're going to be doing your primary survey first to ensure that you can stabilize this patient before you actually obtain your history. So the first thing that you should always check for is that this patient is conscious. So check that the patient is conscious. Quickly check if they are breathing, their airway is patent, and that they are breathing. If they are conscious, talk to them. Keep the patient calm as possible, reassure them, because the more anxious they are, the faster their heart beats. The faster their heart beats, the faster the toxins spread. And just some first aid awareness about snake bites when you're in the field. I know you've watched a lot of these how to survive things on TV, and they tell you, no, if a snake bites you, you could put oil in the mouth and then suck the poison out. Do not do that. Do not cut, do not apply a tourniquet, do not suck the poison out whenever in the field. Just keep the patient calm, immobilize the patient, and call for help. Okay? So back to the hospital setup. So we are keeping the patient calm. We have immobilized the patient, so place them on a bed. And take note that cobra venom is composed of neurotoxins. It's also composed of cytotoxins. So the cytotoxins are going to be causing necrosis of the tissue in that area, but to some extent. And then the neurotoxins are going to be invading the nervous system and affecting the neurons, such that it can also affect breathing. It may cause paralysis in this individual. And more often, it's the respiratory distress and the paralysis that kills individuals. So before this actually turns into a lecture, let's now see what we will do. So your ABCs, check that the airway is patent, the person is breathing. If there are any secretions, suction the secretions, give this person oxygen. If they are conscious, talk to them, reassure the patient, immobilize the patient, and gain venous access and start running your normal saline. Then you want to draw blood for investigations. You're going to be ordering for a full blood count, a cross match, a coagulation profile, urea creatinine, electrolytes, liver function tests, and if possible, you could also order for arterial blood gases. Then you want to clean and incise the site where the snake bit this individual, but of course first confirm the site where this person was bitten. And if possible, confirm the snake. If they have the snake or they have a description of the snake, have a look at the snake that's captured. Usually when a snake bites you, it hangs around that area for about 20 minutes or so. So if they captured the snake or if they saw the snake that bit them, then confirm the fang marks on this individual. Then you can clean that area and incise it. That's also if the person presents in the immediate phase. Later on, then there's no use of you doing this. Then you're going to give this patient anti-cobra venom, And if it's not present, you can give polyvalent anti-snake venom, which usually covers multiple species of snakes. That's if this person doesn't know the type of snake that they were bitten with. And usually this should be given as early as possible, and the time frame should be at least within 4 to 24 hours. The dose usually varies. It's about 20 to 150 mils, and that depends on the severity, the type of the snake. It also depends on the age of the individual. But how we usually give this polyvalent anti-snake venom, we dissolve it in normal saline. So we give normal saline as an IV infusion, 500 mils of normal saline to run at a rate of 20 drops per minute. Then, because there's some neural blockade, we also want to give some drugs such as neostigmine, 0.5 milligrams IV every 5 minutes, together with atropine, 0.6 milligrams, if there's any neuromuscular blockade. Because remember, it can actually paralyze your nervous system. That's why it's important to always put this patients on oxygen, high flow oxygen, and ensure that they're not in respiratory distress. You're going to want to monitor your vitals and your urine output, so ensure that you catheterize this patient. Give this patient tetanus prophylaxis, so ATT 0.5 mils over the deltoid, and of course, start your broad spectrum antibiotics. Ceftriaxone is a very good way to start. Then you can take your history after that. So your history is going to be a detailed description of the snake, if they have captured it, the color and the pattern of the snake, the timing in which this event happened, and the time for the symptoms. Usually, the rule of thumb is that if there's early and intense pain at the site where the snake bit you, then it probably pushed in a lot of venom. And then you ask for some systemic symptoms such as nausea, syncope, and difficulty swallowing or breathing. They may even have some paresthesia of around the mouth. They may have some generalized weakness. Then ask for a prior history to use of or reactions to anti-snake venom or being bitten by a snake before. Ask for any allergies to any medications. Ask for your normal comorbidities, your diabetes, your epilepsies, asthma, TB, hypertension, HIV, and sickle cell. And then, of course, when you do your examination, note the vitals, especially the breathing. The respiratory system is very important, as well as the cardiovascular system, because they can be paralyzed. Then check your airway, breathing, circulation, and also note the fang marks of the snake. So question 3. Answer the following questions. Define compartment syndrome and list major etiological factors. Discuss briefly the pathogenesis of compartment syndrome. With aid of a labeled diagram, explain white shed saline or needle technique for measuring intracompartment pressure in a lib. So remember, compartment syndrome is an entity that results from increased intracompartmental pressure within a limited space, comprising that compromises the circulation and the function of the tissue within that same closed space. So it's going to be characterized by certain things. It's going to be characterized by severe, progressive, and persistent pain that is worsened by passive stretching of the muscle and is not responding to the conventional analgesics. Okay? It's also characterized by paralysis. It's also characterized by paresthesia, pulselessness, pallor, as well as poikilothermia. So the major causes of compartment syndrome include trauma. So you could have things like fractures of the lower limb and the upper limb, which is why we usually put a back slab and not a full cast when they come in. You could have soft tissue crush injuries. You could have vascular injuries. You could have circumferential burns after a burn injury. You could have high velocity injuries, like for example, gunshots. You could even have snake bites. So watch out for compartment syndrome in your patient with snake bites. Then they could be iatrogenic. For example, if you apply a dressing that's too tight, or plasters that is too tight, or a POP that's too tight, or applied too early. Then also lying on one limb in a comatose patient. Then part B, discuss briefly the pathogenesis of compartment syndrome. So this is often edema that's a sequelae of trauma and occurring in a limited anatomical space that raises the tissue intracompartmental pressure. So if it raises the tissue intracompartment hydrostatic pressure, it means that as this pressure is now rising, the pressure within and the pressure on the local venous system in that area is going to also rise. Okay, so the arterial resistance is also going to subsequently rise, and that means that the inflow is going to be reduced. So if you do not do anything for this patient, there's going to be vascular compromise and the enclosed muscles will become ischemic. So what usually goes is that you have the venous outflow that's supposed to be draining blood away from the limb, and an arterial blood flow that's supposed to be taking blood to the limb. So you have this increase in the pressure within this limb that's compressing on the veins first. Now the arteries are still working and bringing blood to this area. So if you're compressing the veins, that means you're compressing the outflow, reducing the outflow, but the arteries are still working, so they're still taking blood to that area. So you're further even increasing this pressure within this compartment beyond 30 millimeters of mercury. And then eventually, as this pressure rises, it's even going to cause compression on the arterial system. And once it compresses the arterial system, then it means that this area is not really receiving blood and is undergoing ischemia, which may lead to necrosis and eventually fibrosis and damage to the surrounding tissues. So as this pressure increases, there's going to be loss of sensation in the distribution that's involved with the nerves, and ultimately there's going to be loss of pulse in that area. So the last question, with an aid of a diagram, explain white shed saline technique for measuring intracompartmental pressure in a limb. So here's the diagram here on your screen. So there is this traditional compartmental measurement setup. So intracompartmental pressure is going to be measured using an 18G needle. So you have an 18G needle that is connected to a three-way. So this one that's on top here, to a three-way stopcock. So this is a three-way stopcock. And as you can see, it's going to be filled with air. You fill the syringe with air about 20 mils in the syringe. And the other half is going to be connected to a mercury thermometer. Then the other half is going to be connected to the limb. So this air, you also have this syringe, this 20 mil syringe. You're not going to fill it with air, pardon me, but this tubing is the one that has air and of course a meniscus there. So the air-filled tubing is going to be connected to a mercury manometer, and a small amount of saline is going to be put in this tube that's connected to the limb. So you have compression of the syringe here that's going to be rising the pressure here in that's going to be rising the pressure in the mercury thermometer. Then wherever now this meniscus, so when you compress the syringe, it rises the pressure till the saline flows into the compartment. So you're going to be pushing this meniscus towards this compartment, and whenever it now flows into the compartment, the pressure at which this saline in this tube flows into this compartment, that's going to be the pressure inside this compartment, because fluid flows down a pressure gradient, so from a region of high pressure to a region of low pressure. So it can only allow this fluid into this leg if the pressure exceeds the pressure in the leg. I don't know if that makes sense. So that's how this technique usually works. So question 4, discuss the pathogenesis of diabetic foot. So remember that in diabetes, there's going to be a high level of glucose. And this high level of glucose is going to mean that there's a good culture media for bacteria, and infections are very common. In addition to this, you have individuals that are having diabetic microangiopathy, meaning that there's going to be some blockage of microcirculation leading to hypoxia. Additionally, patients also have diabetic atherosclerosis. There's going to be a reduced blood supply that may cause gangrene, and the thrombosis can actually be precipitated by infections, causing infective type of gangrene, and the blockage usually occurs in the plantar, the tibial, as well as the dorsalis pedis, which is why it's very important to check for these vessels. And remember also that there's going to be an increase in the glycosylation of hemoglobin that actually causes a defective oxygen dissociation curve that also further contributes to the tissue hypoxia that we have already created. So at the tissue level, there's going to be an increase in glycosylated tissue proteins, which is obviously also going to prevent proper oxygen utilization, and this also further aggravates the hypoxia. And remember also in diabetic individuals, they're going to have diabetic nephropathy, where they have decreased sensations and minor injuries can actually go unnoticed. And they also may have some motor neuropathies, dysfunction of the muscles, even the arches in the foot and the joint. They may also have things like loss of reflexes. So whatever the cause may be, you have this decreased sensation, decreased blood flow means that even the inflammatory response won't be as effective, and healing won't also be as effective. Then you also have some autonomic dysfunction or autonomic neuropathy that may cause the skin to become dry and easily crack. So this predisposes them to having infections that may eventually be cultured by certain organisms, and then this may cause pus, and eventually the patient may need an amputation. Question 5. Describe the steps involved in the synthesis of T3 and T4. Comment on the homeostatic or the regulatory feedback loop. So remember that you take in about 50 milligrams of iodine in the form of iodide that are required each and every year. So it means in a week, you get about 1 milligram per week. And usually the source of this iodine is iodated salt. And this iodine is going to be found bound to proteins. And it has to be converted to iodide by glutathione. And because this iodide is very easy to absorb from the gut. So iodine is going to be absorbed orally or ingested orally, and is going to be absorbed from the intestines into the bloodstream. And it moves in a similar way to how chloride actually enters into the bloodstream. So remember that absorption of sodium ions from the epithelium is going to create an electronegativity in the lumen, so in the chyme that's present in the lumen. And the electropositivity of the paracellular spaces is going to be created in between the spaces in the cells. So it means that you're creating a negative or environment inside the lumen, and iodide is a negative ion. So it's going to force the iodide to squeeze in between the cells, which is known as a paracellular route of absorption. So it's going to be flowing down an electrical gradient. So the iodide is then going to enter into the bloodstream and is eventually going to be taken to the thyroid gland, where it's taken into the thyroid glandular cells and the follicles. So remember that the synthesis of T3 and T4 happens in steps. So the first step is known as iodine trapping. I think I have a diagram for this. So the first step is known as iodine trapping. So this is the basal side of the follicle. This is the lateral side. This is the apical side. So the basal side here has got two important channels. There's this NIS, which just simply stands for sodium iodide symporter, and there's a sodium potassium ATPase pump. So remember that the rule of thumb is that almost every cell has sodium potassium ATPase pump at the basolateral side or at the basal side. So remember the stoichiometry of this pump. It pumps out 3 sodium ions in exchange for 2 potassium ions at the expense of 1 ATP molecule. And it is this energy that is released from this process that actually drives the trapping of iodine, where iodine is taken in with 2 ions of sodium via the sodium iodide symporter into the follicle. So you refer to this first step as iodine trapping. Then this iodide is taken out into the colloid via an exchanger that is referred to as pendrin. You take in a chloride ion in exchange for an iodide ion. Then now within this colloid, you have an enzyme that's known as thyroid peroxidase. So the next step is oxidation of iodide to iodine. So remember that oxidation is the loss of electrons. So it loses electrons and it forms iodine. So the second step is oxidation, catalyzed by thyroid peroxidase. Then the iodine is added to the thyroglobulin molecule. You refer to that as organification or iodination. So you can refer to it as iodination or organification. This process is also catalyzed by thyroid peroxidase. Now remember that when you have these iodine molecules being added now to the thyroglobulin, you're going to be forming monoiodothyronine. If 1 molecule is added, you're going to be having diiodothyronine if 2 molecules are added. Then the monoiodothyronine and diiodothyronines begin to combine with each other, a reaction that's known as coupling. That's also catalyzed by thyroid peroxidase. So a mono plus a di gives you triiodothyronine, which is T3. A di and a di gives you tetraiodothyronine or thyroxine, which is T4. Then a di and a mono gives you reverse T3. So that's how you have T3, reverse T3, and T4. Then you have pinocytosis. That's going to pinch off a portion of the thyroglobulin molecule, forming this endocytic vesicle that eventually fuses with the lysosomes, and then they're going to secrete their protease enzymes and then cleave off T3 and T4. Then T3 and T4 are released into the blood. And remember that T3 is the biologically active, but T4 is the one that's synthesized in greater amounts. And then at the peripheral tissues, T4 can be converted into T3 by the enzyme deiodinase. Then there's a feedback loop that's going to be there to regulate the production of these hormones. So these hormones can actually feed back to the pituitary gland, the anterior pituitary gland, and the hypothalamus. So when T3 and T4 are actually produced, they can go and inhibit the production of the hormone, thyroid stimulating hormone from the anterior pituitary gland. They can also inhibit the production of thyroid releasing hormone from the hypothalamus. And therefore, if the levels of TRH, which is thyroid releasing hormone, and TSH, thyroid stimulating hormone, are low, it means that the production of T3 and T4 will also be reduced. So you refer to this as the negative feedback loop. So the last question, and indeed the final one, I know this was a very long episode, so answer the following questions. Discuss the importance of digital rectal examination in a person with rectal bleeding. List the following up investigations. So number one, you want to do a digital rectal examination to obtain any feces, or you're going to be taking this feces for a fecal or cord blood test. This is usually done to screen for any GI bleeding or colon cancer. And obviously this confirms the bleeding. When you do the digital rectal examination, you can see that there is blood on your glove. Then this can also be done to check for the causes of rectal bleeding. Sometimes it could be the fissures that are causing bleeding. Sometimes it could be hemorrhoids. Sometimes it could be the masses. So you can feel these things when you do your digital rectal examination. It is also, if there are hemorrhoids, you can do this digital rectal examination to actually assess the extent of the hemorrhoids, if there are any swollen veins in the anus that you can feel. Then if there are any tumors that are bleeding, you will also be able to diagnose any tumors or masses that you can feel. You can also assess for the size of the prostate, because sometimes this person could have a prostate cancer that has actually metastasized to the bowel and causing the bowel bleeding, the lower GI bleeding. Then, of course, you also want to assess the functioning of the anal sphincter, because there may be some fecal incontinence. Then list the following up investigations. So you want to do a prostatic specific antigen levels, which is PSA. You also want to order for a perineal or a pelvic ultrasound. You can do an abdominal x-ray. So we're ordering for a PSA because it may be elevated in conditions like benign prostatic enlargement as well as prostate cancer. We are doing a perineal and a pelvic ultrasounds because there may be some masses that may be present there. We are also ordering for abdominal x-ray because and a pelvic x-ray because there may be some metastasis to the bones of the pelvis, and there may be some calcifications in terms of tumors that may be present. Then you also order for an abdominal ultrasound. You may do a fecal or cord blood test or fecal or cord test to check if there is presence of blood in the stool. You do a proctoscopy or colonoscopy to, of course, rule out any pathologies like that may be there, like masses or tumors. Thank you for spending your time to listen to this episode. Stay tuned for the next episode. Tell a friend to tell a friend that we're answering questions on the channel. Subscribe.